seeing each other today. So today I'm going to be presenting on a partial nephrectomy, intraoperative approach and management, and just to speak about if size matters. I'm going to start off with talking about a case that we had here at Grooteskier. We saw a patient, Mr. MB, who was a 52-year-old male patient, initially presented in 2019 with abdominal masses bilaterally. But otherwise, in terms of his medical history, he is known with hypertension, which was very poorly controlled, dyslipidemia, and chronic kidney disease with a baseline creatinine of about 120, and GFR at that time was 54. We did a CT scan for him at that time, which showed a left lower pole mass, which is nicely seen here on that left side, which was about 11 centimeters by 15 by 11 centimeters. He also had a right upper pole mass, which was about 15 by 17 by 22 centimeters. On imaging, we assessed him as having clinically 2 TB N0M0 disease. At the beginning of 2020, we decided to do a biopsy for him, as indicated by and confirmed that he had bilateral papillary, on the left side, confirmed that he had papillary renal carcinoma. Unfortunately, the patient was lost to follow up for 2 years, then presented in December last year with abdominal discomfort. On further workup, he was found to be in congestive cardiac failure. He had now developed acute and chronic kidney disease with a creatinine that had now gone up to 262 and a GFR of 22. Further workup was done, a CT scan was done for him. Unfortunately, it was uncontrasted this time, as his renal function did not allow us to do a contrasted scan. The masses had increased in size bilaterally. And we did a renal nephrometry score for him and found that the left mass scored 9 and the right one was 10, basically high complexity scores. We did a further workup for him, which included an ultrasound Doppler to assess the IVC, as we couldn't give the gentleman contrast to see any if there was any thrombus. Fortunately, there was none. We did a renogram for him to assess function of these kidneys, which showed that the right kidney was actually only functioning 17%. At this time, we decided to do a bilateral partial nephrectomy for the gentleman. We got other medical colleagues involved in terms of internal medicine, the nephrologists, the ICU team, and the anesthetic team, and we optimized the patient as much as we can. Oh, okay. So nephron, sorry about the slide. Nephron sparing surgery includes partial nephrectomies and tumor enucleation of masses and thermal ablations. So today we're going to focus on a partial nephrectomy, which basically includes local resection of a whole tumor while preserving a large proportion of the renal parenchyma, which assists in preserving normal function of the kidney. It provides long-term therapy, hopefully for the patients with cancer, and complications for partial nephrectomy can be renal insufficiency, especially with patients that are known already to have renal disease, urinary leaks. So urinary leaks, usually we diagnose them by taking fluid from the drain and assessing for creatinine levels, and can be managed conservatively in terms of what we call the three-tube procedure, where you leave a drain for prolonged amounts of time, you try to insert a DJ stent, and you leave a transurethral catheter inside you. Patients can also develop fistulas and obviously bleeding. So the aim of a partial nephrectomy is not to get margin width, but rather just to achieve a final negative margin. And recurrence, unfortunately, can occur with partial nephrectomy at a rate of about 1.4 to 10%. Like I said, renal function post partial nephrectomy can decrease, and is dependent on the quality of the parenchyma at the time, the number of nephrons that were preserved, and of course, ischemic injury that can be sustained during the operation and post-op because of also because of drugs that we give to the patients that can be nephrogenic. Renal dysfunction in later stage can also decrease after the partial nephrectomy, secondary to hyperfiltration, which occurs if there's a more 50% or more reduction in the renal mass after the partial nephrectomy. Indications for partial nephrectomy, as we all know, all small renal masses, you can do a partial nephrectomy, but they can also be surveilled. Clinically, T2 and T3A masses, we can do partial nephrectomies for them if it's partially feasible, especially if the patient has bilateral renal tumors, as is our patients. Patients have solitary kidneys. Patients have threatened or decreased contralateral kidney function. Patients who have chronic kidney disease, and patients with familial syndromes that are causing the renal masses. So with our patients, we always do pre-operative evaluation for any operation. And in terms of our partial nephrectomy, we like to do our routine bloods, which include the FBC, UNE, CMP, and LFTs. The CMP and the LFTs also more indicated in patients with more advanced disease, just to exclude any maybe paraneoplastic syndromes. Obviously, chest X-ray, ECG, and our urine MCNSs. UNE also obviously helps us to assess the patient's baseline renal function. Imaging, we like to do a dedicated CT scan, which is the standard imaging for renal masses. We can MRI and ultrasound can also be used. MRI helps to assist in assessing thrombus in the IVC, and obviously MRI and CT can be done with contrast, which will give us the dedicated images. Our imaging needs to help us to assess the morphology of the actual tumor, also help us assess for any lymph nodes, any distant mets, and also help assessing in pre-operative planning in terms of the surgery. How many vessels, where are the vessels that are leading to this tumor? Also, we do our complexity profile for the mass, the nephrometry score, which I think we all know. There's others, but we here usually do the renal nephrometry score, which consists of assessing the mass's radius, whether the mass is exophytic or endophytic, the nearness to the collecting system, whether the mass is anterior or posterior, the location to the polar lines. Part of the evaluation also includes a renal biopsy, multiple indications for renal biopsies, especially if, in our case, we're planning to do nephron-sparing surgery like partial nephrectomy. Another important one is if you're going to surveil the patient, it's important to do a biopsy just to make sure you have a histological classification of that mass. You don't want to ever surveil a renal mass that has aggressive histology. And other things that you need to consider, like we had done for our patients, review by the nephrologist if you suspect that your patient might have a need for dialysis or intervention from the nephrologist after ICU care review. And obviously you need to ensure there's bloods cross-matched for your patients, because bleeding is a complication of the operation. Prophylactic measures. So it's been described that one can give bowel prep for the patient, although in open surgery, it's really not indicated. The indications for bowel prep could be if you think that your mass is eroding into the intestine, or some patients actually prefer to give bowel prep, especially if they're going to be doing laparoscopic procedures. Preparing your theater as well, part of the pre-operative preparations. If you're going to do open surgery, ensure you have all your retractors there, ensure you have all your clamps there. If you're going to do laparoscopic operation, ensure all your laparoscopic instruments are there, your needle holders. It's really a bit of a headache trying to find things while you're operating. Also for your partial nephrectomies, you must always have your hemostatic and your hemostatic agents ready when you are going to do your rhinorrhaphy. So approaches for partial nephrectomies, we have open procedures and we have minimal invasive procedures. I'm going to start by talking about open surgical procedures. Open surgical procedures, the hallmark of it is exposure. So obviously with open surgery, it's when you really want good exposure. Patients have large renal masses and patients who have previous abdominal operations, and you're going to struggle with entering that abdomen, you'd want to do an open procedure. One needs to also consider the anatomical organs that are in the abdomen when you open at the sides of your incision. So the different approaches, we have flank approach. So your flank approach can be divided into subcostal, supracostal, and dorsal lumbar. With your subcostal approaches, we have our patients in lateral position with the costal margin and the iliac crest flexed. Obviously, all the patients must be protected in terms of pressure points. And with our subcostal flank incision, we do an incision by the 11th and the 12th rib. This incision really gives poor exposure to the renal hilum, and you can't. It's not indicated for large masses. So for our patient, it wouldn't be ideal. Supracostal flank incisions, patient is in the same position, but now we just go higher in terms of our incision. We go as high as the 9th and the 10th intercostal space when we open up the patient. Your dorsal lumbar incision, we do a dorsal lumbar lobectomy, which goes through the dorsal lumbar fascia. The nice thing about this incision is that you're going through fascia and you don't go through the muscle. So for the patients, there's less pain because the muscle is not incised. The patient is in the prone position, so it can present issues, especially when you have to ventilate the patient. This incision unfortunately gives us lack of exposure to the hilum and large renal masses, so not quite for our patients. Anterior approach, we have anterior approach where we have our classic midline approach, where an incision is done in the midline of the abdomen, the patient sitting, the patient in the supine position, where we do an incision anywhere from the xiphisternum down to the suprapubic area. This incision usually gives us great exposure for the great vessels in the hilum, and is usually done during trauma cases where you want to explore vessels, you want to explore the kidney, an incision that's loved by the trauma surgeons. Then we have a subcostal incision. Like our subcostal for the flank, you do go in the subcostal region about 2 centimeters from the subcostal margin, from the costal margin rather, down to the 12th rib. This incision is ideal for small tumors. Then we have a chevron incision where you get great exposure to the kidney, the renal pedicle, the great vessels. It is good for large complex masses. This incision is almost you could call it 2 subcostal incisions, where your incision starts from the one side to the other side, 2 centimeters below the costal margin, all the way across to the xiphisternum. You turn around down to the other side, up to the tip of the 12th rib. Then we have a transverse abdominal incision. Transverse abdominal incision is classically described for pediatric patients, but also gives good exposure. This incision can be done supraumbilically, infraumbilically. It gives us great exposure to the renal pedicles, especially early, but it does require one to actually dissect through the mesentery of the bowel. Then we have a thoracolumbar approach, where the patient's in a semi-oblique position, and the pelvis is rotated slightly horizontally. Good exposure for large renal masses as well, upper pole masses, tumor with venous involvement, and tumors with in adjacent organs, so T4 lesions. Once we've decided your approach, you need to decide what procedure you're actually going to do when you are operating the patient. So different procedures have been prescribed for different lesions, depending on the size, depending on where the mass is. So first, we have enucleation of a small cortical lesion. So like I said, we need to be prepared. With this approach, you don't really need to cool the kidney, but cooling should always be available in case you need it. So you prepare your hemostat bolsters, you prepare your platelets, you get ready with your with everything. The kidney is exposed and the fat around the kidney is removed, except on the area where your tumor is. You identify the tumor, you put your vessel loops around your vessels. And like I said, you don't need to occlude the vessels because the theory behind this is that the tumor is quite small and you should be able to get through the lesion without a lot of bleeding. You give mannitol. Your tumor is marked with a cautery, and then the tumor is removed with a pseudo capsule. So you don't remove any parenchyma in this approach. It's just the tumor and the pseudo capsule that's removed. Then you assess your collecting system and you do your rhinorrhaphy. The second approach is the wedge resection. This resection is good for large cortical tumors, where the tumor once again is exposed. And then once you found your tumor, you need to mark the tumor. And you mark about 5 to 10 millimeters of normal renal parenchyma around the tumor mass. The tumor mass will be removed with this normal parenchyma. In this approach, we would like cooling, and the kidney would ideally be cooled to 20 degrees for about 15 minutes. The renal artery is clamped and and also the renal vein can be clamped to have a more of a bloodless field, but some surgeons prefer not to. The tumor is excised, like I said, with normal renal parenchyma. Once again, collecting system is repaired, rhinorrhaphy is done. Then we have a segmental nephrectomy. Segmental nephrectomy is good for large polar tumors. This procedure is great in the sense that you get decreased ischemia time to the rest of the kidney and a bit of a decreased bloodless field. The renal pedicle is dissected along with a segmental branch that supplies the actual tumor. You clamp that segmental branch. Once clamping that segmental branch, you get ischemic markers. So the kidney becomes ischemic where that branch is supplying. Then you mark that area of ischemia. This is where you're going to cut you resect your tumor. You give your mannitol, you cool the tumor, and then you clamp your pedicle. The segmental vessels are then ligated, and then the tumor is excised along this ischemia line. Once again, you assess your kidney, make sure your collecting system is intact, repair any injuries, and you do your rhinorrhaphy, and then you can unclamp. Moving over to minimal invasive surgeries for the kidney, we have laparoscopic access, we have robotic access. In terms of laparoscopic, we can do retroperitoneal laparoscopic surgeries for kidneys. This allows us to explore the retroperitoneal organs without entering the peritoneum and not disturbing any of the peritoneal organs. The insertion of a balloon device to dilate the area and atraumatically move the perinephric fats and other fats around the kidney allows for this technique to be more feasible. The advantage of this technique is it allows for rapid access to the renal pedicle. And like I said, you don't mobilize bowel. So there's less chances of getting bowel injury, less ileus later on. There's less contamination of the peritoneum in case something should happen. And they describe that this technique is actually quite ideal for patients with a larger BMI. The disadvantages, of course, is a decreased working space, and the trocars that you actually put during this technique, they're very close together and can make your work technically difficult. And this approach has a very steep learning curve. And laparoscopic, we also have transperitoneal access, which is the access which is most widely used by many surgeons. The ports are inserted into the anterior abdominal wall. You enter the peritoneum. This allows you to have a large working space. You have familiar landmarks in the abdomen. You can see your liver, you can see your spleen, and also allows you to have several options for placements of your trocars and other instruments. Like I said, here we have to mobilize other organs, you have to mobilize bowel, and there's risk of injuries in ileus with that. Then we have your hand-assisted laparoscopic surgery, which is not widely used anymore. But basically this is your placement, is your laparoscopic surgery assisted by placing a hand-assist device along the anterior abdominal wall of the patient. It helps to give tactile feedback to the surgeon, and it improves your 3D orientation because the surgeon can physically touch and feel the organs in the abdomen. The surgeon also helps, the surgeon can also help in facilitating dissection with the hand ports, retraction, and hemostasis. And this also has been found to decrease conversion rates from laparoscopic to open. Robotic surgery, a nice approach which we've got here at GSH, and basically with this approach you have a patient console, a surgeon console, and you have your tower with your screens. The surgeon is sitting at the surgeon console and manipulating the arms of the patient console. This allows for surgeons who have limited laparoscopic skills to still perform minimal invasive surgery. It can be done for transperitoneal and retroperitoneal, it can be done transperitoneal and retroperitoneal. It can be done via multiple ports or single ports. The advantages of this approach allows 3D vision of the surgical field. There's a manipulation of the instruments in many degrees. There's elimination of patient tremor. It's good for the patient's posture and low back pain with this procedure, hopefully. And you have the ability to scale your motions. So one of the disadvantages that I've heard feedback from is that there's decreased tactile feedback with this. So once the minimal invasive approach has been chosen, the procedures one needs to do once we've gained access into the patient's mass, the tumor needs to be located and excised. So obviously your initial dissections are done. If you're going transperitoneal, your bowel is mobilized. Your liver, your spleen, your duodenum, and then your tumor is identified either by dissection and inspection, or we can use ultrasound guidance to identify the actual tumor. The fascia is entered, and then you can use your monopolar scissors to cut the capsule around the tumor. Once you've marked it, once again, monopolar mannitol is given. The hilum is also clamped here, but we unfortunately do not have cooling of the kidney, but it has been described, but not really feasible with minimal invasive therapy. The next things to consider is hemostasis. So hemostasis usually can be achieved by doing urinaraphy, either with sutures, with or without your hemostatic bolsters, with your rolled up Surgi cells, or with or without your sealing agent. Your collecting system again needs to be assessed and repaired if there are any injuries. So your collecting system here can be repaired either directly by suturing the collecting system, or even just by closing the parenchyma and the capsule over the defect. And of course, you need to leave a drain inside you. Like I said, your ischemia, it has several techniques have been described, but are really not feasible in minimal invasive surgery. But can be considered if the patient's got a solitary kidney or significant renal dysfunction. And warm ischemia time is what we have in minimal invasive kidney surgery, which can be achieved by clamping, obviously, your vessels. Maximum should be at least 30 minutes. And there are several maneuvers that you can do to decrease your warm ischemic time. So some surgeons have decided to do early unclamping, which basically means that once you've clamped your vessels, you unclamp them before you do urinary. But obviously then your surgical field might just be non-bloodless. You might have a surgical field that has some bleeding and impair your vision, but obviously it shortens your ischemia time. Some surgeons prefer to do off-clamp partial nephrectomies. This can be done for small exophytic tumors. Of course, this means that you don't clamp your renal vessels at all. It's been shown to improve your renal function and GFR, and these patients obviously can be done for patients who already have proven renal dysfunction. Then another maneuver is selective artery clamping, similar to your segmental partial nephrectomy, where you can get a bloodless field by clamping the actual artery that's supplying the tumor. This is assisted by the use of an ultrasound Doppler and your Firefly, which is injected and helps to identify the actual vessels. They also describe parenchymal compression, where you physically compress the kidney itself with your instruments to just while you are suturing while you're doing your urinary. So I just looked at some articles in terms of our radical nephrectomy topic versus, sorry, this is supposed to be not radical, yes, radical nephrectomy versus nephron sparing. So the first article I looked at basically was an article that looked at survival outcomes of patients with large renal masses. They looked at patients with renal masses that were more than 7 centimeters. This was for clear cell carcinoma. So these patients were treated with nephron sparing surgery versus radical nephrectomy. Basically here, this was a prospective study where, like I said, they wanted to analyze oncological long-term outcomes, which was the primary outcome for patients who had a partial nephrectomy versus a radical nephrectomy for tumors that were larger than 7 centimeters. Secondary outcomes they looked at was surgical complications such as bleeding, prolonged hospital stay, post-operative pain, and renal function. In this study, basically 123 patients with nephron sparing surgery and radical nephrectomy with large masses were assessed in terms of database from 1980 to 2010. Basically, in the study, they found that the overall survival, the cancer-specific survival for patients who had nephron sparing surgery was actually much improved. In their data, they assessed a lot of patients, including patients who actually didn't have large renal masses. But this graph specifically shows the results from patients who they assessed who had masses which were more than 7 centimeters. And they concluded that small renal masses, yes, you can manage with a nephron sparing, but also that masses over 7 centimeters, when technically feasible, can be managed with nephron sparing, where the complications are and morbidities are really not that significant, and patients still did have overall survival and cancer-specific survival that was more superior. The next article I decided to review was an article done in America where patients had partial nephrectomies and radical nephrectomies for masses that were T1B, T2 renal masses. This was a systemic review and meta-analysis. So in this paper, they did a meta-analysis of all studies that were done for patients with T1B to T2 renal masses. And it was a systemic review from literature from up to and including December 2015. They assessed all the cases, all the papers that they found, and ultimately 21 case control studies were included in the study. I summarized the data in this table. Basically, the take-home message from this paper was that the radical nephrectomy, yes, has lower bleeding in terms of complications, but they found that the partial nephrectomy actually had better post-operative renal function in the patients, they followed up the patients for up to 5 years. They had lower tumor recurrences, and they had low cancer-specific mortality. Once again, in this paper, they also concluded that it's feasible to do partial nephrectomies for patients who have T2 lesions, and the surgical morbidities are acceptable for these patients. Put the slide in just to also highlight that in the guidelines, the European guidelines, they do say that we can offer partial nephrectomy for patients with T2 tumors in solitary kidneys or patients with chronic kidney disease, if technically feasible. This article I just wanted to include because I just wanted to compare open versus minimally invasive surgery. This was an article done in Asia, a retrospective analysis of 300 patients. And the aim basically was to compare outcomes amongst robotic, laparoscopic, and open partial nephrectomies with a 5-year follow-up for these patients. The outcomes that they compared were functional in terms of renal function and oncological outcomes. They basically analyzed patients from 2006 to 2012. So on this graphs, basically we can see that the outcomes in terms of robotic, laparoscopic, and open partial nephrectomy, the first one there shows that there was no significant difference in local recurrence between the three surgical approaches. There was no, in the second graph, there was no significant difference in the distant mets after follow-up. There was the third one, there was no significant cancer-related deaths in after 5 years of follow-up. The only significance that was found was that partial nephrectomies done by robotic access showed a lower incidence of chronic kidney disease upstaging after follow-up. So if robots is feasible and accessible, then one should consider using it for our partial nephrectomies. Back to Mr. MB. So Mr. MB, we decided to do an open partial nephrectomy for him. We inserted ureteric catheters initially to help us identify the ureters during our dissection, and obviously to also help us identify any collecting system injuries after our resection. We decided to do an infra-umbilical transverse abdominal incision, which gave us great exposure, gave us rapid access to the renal hilum, but the great vessels, but obviously we had to dissect first through the mesentery and the bowel. We first started with a resection of the left renal mass, because as we assessed the CT scan, we found that this left renal mass was actually growing right across the abdomen, and would be a problem to access the great vessels if we had started with the right. So it allowed us to actually, when mobilized and resected, it allowed us to get good access to the great vessels and the right-sided hilum. Minotaur was given as standard, and both the vein and the artery were clamped. and the mass was removed. We checked our collecting system for any leaks and repaired the collecting system. Minimal leaks were actually found. The parenchyma was closed with some hemostats and plagiates hemostats that were constructed with some Surgicel, and the fascia was closed as well. The warm ischemic time for our operation for this patient on the left was 16 minutes, on the right was also 16 minutes. During our dissection, we also found that we had one large lymph node, and we decided to dissect it and send it for histology as well. On follow-up of the patients, his histology did come out, and basically it confirmed that the patient had bilateral papillary renal cell carcinoma. And on the left, we had a grade 2, ISUP grade 2 lesion, limited only to the kidney. All margins were negative, no sarcomotoid or rhabdoid features, with 15% tumor necrosis. On the right, we had a grade 2 ISUP grading. Once again, negative margins, no sarcomotoid or rhabdoid features, but with 90% tumor necrosis. So does size matter? In my view, it matters, but to a limitation. Renal masses can be managed with partial nephrectomy, and actually large renal masses should actually be managed with partial nephrectomy, especially if there is indications, like if the patient's got bilateral renal masses as per our patients, if the patient's got chronic kidney disease, if the patient's got familial syndrome. One should try to do partial nephrectomies for these patients. It's been shown that partial nephrectomies could give good functional outcomes with good oncological outcomes compared to radical nephrectomy. The post-operative complications, yes, bleeding is a post-operative complication that is significantly higher in partial nephrectomy, but can be a complication that can be mitigated. Pre-operative planning is very essential. Preparing your patients, preparing yourself as a surgeon, looking at your images, and doing a proper surgical plan. Exposure is essential. So I would suggest with these large masses, partial nephrectomy can be achieved if you go for maybe an open approach that will allow you to get good exposure to the masses, to the renal hilum, to the great vessels, and obviously surgeon expertise. Most of the studies that were done, that I went through, were done in institutes where there was high volume surgery. So it is important that the surgeon is comfortable and has done a number of these operations in order to be successful when dealing with these large renal masses. Thank you.
Yeah, thanks a lot. Thanks to Dr. for an excellent presentation on the recent case we've done. Just gonna stop sharing there so I can see. I don't know if anyone has a question for us. Any comments? Yeah, I think she touched on a few points that I wanted to discuss. I mean, obviously, as mentioned, the idea on doing partial nephrectomy is just ensuring that you're ready and you plan before you do the procedure. Obviously, there is always a chance of doing a nephrectomy radical when, in fact, having planned a partial. She mentioned the role of putting ureteric catheter to use methylene blue so it can help you close the collecting system to try and reduce the risk of leaks, which we've not been seeing much because of that. The other thing is we're moving towards doing more complex nephrectomies now, partial nephrectomies open, and we're leaving the other ones that are sort of less complex for the robot. And obviously we're getting better. I mean, I think we all know the data is quite clear that the outcomes probably slightly better with the robot, and easy to suture and close. And we can use Firefly, super select vessels you want to clamp. It's a bit quicker. You can also do it. Sorry. Oh, yes. You mean arch overclave, you mean? Oh, yes. I think Sagasa mentioned that earlier as well, that some surgeons would just clamp the artery, not necessarily clamping the vein as well. So I mean, it's a very interesting topic. I think everyone is really approaching more complex cases. I also wanted to discuss the role of frozen section and also talk about the significance of positive margins. But I think in the interest of time, we won't go to that. I don't know if there's any questions on the floor, comments. Right, we do apologize for the issues with the technicalities in the morning. But thanks a lot to everyone who joined. We'll see you guys the next week. I think